Hello, this is Mitchell Shiffman. I am director of the Liver Institute of Virginia at Bon Secours Mercy Health. Today, we're going to be talking to you about patient management for primary biliary cholangitis. Our first section deals with patient management in the first line and treatment goals, along with risk stratification. So when we see a patient and we suspect PBC, we want to look for early signs and symptoms. And these typically include fatigue, arthralgias, myalgias. Importantly, the main physical signs of PBC or symptoms of PBC are itching, dry eyes, and dry mouth. So the classic patient with PBC comes in scratching their arms and legs, has a large bottle of water to drink from, and is using eye drops for their dry eyes. But the presentation is very heterogeneous, and some patients are completely asymptomatic, while other patients may have all of these symptoms of severe itching, dry eyes, dry mouth, arthralgias that I've talked about. The current diagnostic criteria involves liver chemistries and an elevation in the alkaline phosphatase level. That would trigger you ordering an anti-mitochondrial antibody, which is positive in 95% of patients with primary biliary cholangitis. 90% of patients with PBC are women, but don't forget PBC in men, as it accounts for 10% of patients with the disease. 95% of patients with PBC have a positive anti-mitochondrial antibody. So liver biopsy will be necessary to confirm the diagnosis of suspected PBC in a patient with an elevation in alkaline phosphatase in about 5% of the patients. Other chemistries that can be ordered to help make us think of the diagnosis include elevation in immune globulins, particularly IgM, and an elevation in the gamma GT. Once we've made a diagnosis of primary biliary cholangitis, we need to assess the patient's risk for disease progression. The most important single factor in assessing the risk for progression is the alkaline phosphatase. The higher the alkaline phosphatase, the more likely and the more rapidly the patient will develop progressive liver injury, fibrosis, and eventually cirrhosis. Bilirubin is also an important risk factor for disease stratification. Any elevation in bilirubin, even a minor elevation, is critically important in this disease and indicates more advanced fibrosis and possibly even cirrhosis. Bilirubin elevations as mild as 2 times upper limit of normal, which is really only a bilirubin level of 2 milligrams per deciliter, almost doubles the risk of developing cirrhosis or decompensation and need for liver transplantation. As the disease progresses into cirrhosis, that bilirubin is going to rise exponentially. For those of you that like to enter data into algorithms and get a risk stratification score, there are 2 well-known scores that are highly reliable in predicting the 5, 10, and 15-year mortality or need for liver transplantation in this disease. And this is the GLOBE score and the UK PBC score. Once we make a diagnosis of PBC, we do need to monitor the patients on a regular basis. We can assess where their fibrosis is at this time by many different methods. And we need to monitor that ALP, bilirubin, liver transaminases on a regular basis. Another important extrahepatic manifestation is bone density. Women with PBC have accelerated osteopenia and osteoporosis and develop osteoporosis at a much higher rate than age-matched control women. It's important to do a bone density at baseline and to monitor bone density every few years. The goal of treating patients with primary biliary cholangitis is to lower the alkaline phosphatase, ideally to normal. But we want to get it as low as possible. Again, important, ideally to normal. Simply lowering alkaline phosphatase a few hundred points and having it sit at in the 200s is really not acceptable in this disease any longer. We know that the elevation in alkaline phosphatase is related to disease progression, so we want to get it down. The first-line therapy, and a very well-tolerated therapy for this, is ursodeoxycholic acid. Ursodeoxycholic acid will lower alkaline phosphatase. Urso is a very well-tolerated medication. The main side effects of urso are itching, which only occurs in about 2% of patients, and diarrhea, which also only occurs in about 2 to 5% of patients. So very, very well tolerated. The vast majority of patients do respond to urso. Their alkaline phosphatase will come down, but it may not reach normal, except in a very small minority of patients who are recognized as having PBC with only modest elevations in the alkaline phosphatase. Your chance for achieving a normalization in alkaline phosphatase with urso alone is great if your alkaline phosphatase is under about 200 to 250. The average decline in alkaline phosphatase with urso is usually about a couple of hundred points. So if that alkaline phosphatase is very high, you use urso first line, but be aware that you're not going to, it's very unlikely to get the alkaline phosphatase down to normal. Now, the time at which it takes to get a stable alkaline phosphatase once you start urso is about 9 months to a year. And so once I start patients on urso, I bring them back at 1 month just to make sure they're tolerating the drug. Many patients do tolerate the drug, but a very small percent of patients don't. The main reason for not tolerating the drug is kind of nausea. And if you start with full dose, nausea tends to be more common. And so what I've learned to do is to start at a low dose and work up stepwise. And if the patient develops nausea, go back to the previous dose, maybe cut the tablets in half, start lower, and then eventually work your way up. And the patient should be able to tolerate the full dose by doing that within a month's time. I then see the patients back at 3-month intervals and monitor the alkaline phosphatase. And it typically plateaus in most patients about 6 months. But in some patients, they'll continue to have a decline in the alkaline phosphatase and will not reach stability until about a year. Again, if you remember what we said just a few minutes ago, the better the alkaline phosphatase response and the lower the alkaline phosphatase, the less likely you're going to progress and eventually need liver transplantation, or you will experience mortality. So patients that have a lowering of the alkaline phosphatase to normal or near normal will have the best long-term outcomes and a very low risk of mortality and need for liver transplantation. Patients who continue to have elevated alkaline phosphatase despite urso will have progression of their disease and increased rates of liver transplantation and mortality. Once we have patients on stable doses of URSO, it's really important to monitor them on a regular basis. Again, we want to make sure that alkaline phosphatase stays very low as possible. And it's critically important to recognize when patients have really failed to have a good response with URSO and their alkaline phosphatase remains elevated to unacceptable levels. We can periodically assess their GLOBE score or their UK-PBC score. As long as that alkaline phosphatase remains elevated, both of these scoring systems will indicate increased rates over time of mortality and need for liver transplantation. Once patients are very stable with very low levels of alkaline phosphatase on URSO, we can reduce the monitoring from every 3 months down to every 6 months. So in summary, I think once we have a patient stable on URSO, we want to assess their risk of progression and divide it into low, intermediate, or high risks. If the alkaline phosphatase is getting close to normal, under 1.5 times upper limit of normal, and their bilirubin is normal, and by some sort of fibrosis assessment, whether it's FibroScan or another modality, there is minimal or no fibrosis, let's just say stage 0 or 1 fibrosis, these patients are at very, very low risk to progress. They'll have a very low UK-PBC or GLOBE scores. Patients with elevated alkaline phosphatases greater than 1.5 times upper limit of normal have a higher risk. If their bilirubin is rising, it's a higher risk. If their albumin is down, it's a higher risk. And these patients have more advanced fibrosis with fibrosis assessments and may even have cirrhosis. And these clearly are at-risk patients and need to be monitored more closely and considered for second-line therapies. Finally, when patients start to decompensate, they need to be considered for liver transplantation. This would include bilirubin greater than 2, elevated liver transaminases, worsening pruritus, and development of complications of cirrhosis, such as esophageal varices, ascites, or hepatic encephalopathy. Hello, this is Mitchell Shiffman. I am director of the Liver Institute of Virginia at Bon Secours Mercy Health. Next, we want to talk about treatment sequencing beyond first-line setting to optimize outcomes in patients with PBC. As we mentioned in the first section, our primary treatment for patients with PBC is ursodeoxycholic acid. And we're going to be monitoring the alkaline phosphatase once we start this agent. And once we see the alkaline phosphatase plateau, if that is plateauing at an unacceptable level, we need to consider second-line therapy. Now, classically, that unacceptable level has been greater than 1.5 or 1.67 times the upper limit of normal, which is generally an alkaline phosphatase greater than but greater than 200. You can usually, that's an easy number to remember, and it's reasonably accurate at that 1.67 mark. So any patient who plateaus their alkaline phosphatase, and that plateau, as we mentioned earlier, can occur as early as 6 months, but clearly, if the alkaline phosphatase is elevated by 1 year of URSO, we need to start thinking about second-line therapies that we're going to add on to URSO to further bring down that alkaline phosphatase. Now, for the past decade, we've only had a single agent to add on a second-line therapy, and that's obeticholic acid. This was approved for the treatment of primary biliary cholangitis as second-line therapy almost a decade ago, and is pretty well tolerated in the majority of patients, but does have significant side effects. The biggest side effect of obeticholic acid is itching, which is very common in patients with PBC. And about 50% of patients with PBC report worsening of their itch on obeticholic acid. So we've known for a long time of having this drug that we need better second line therapies. And fortunately, two new therapies have been approved for the treatment of primary biliary cholangitis this year in 2024, and that is elafibranor and citalopar. Both of these agents are PPARs. One, elafibranor, is a PPAR alpha delta agonist, where seladelpar is a selective PPAR agonist. And these can be added on to patients with PBC in patients who have had an unacceptable response, meaning their alkaline phosphatase is over 1.5, 1.67, clearly greater than 200 units. Well, in terms of response, let's go back and talk about obeticholic acid. So obeticholic acid is started at a dose of 5 milligrams per day. And in patients with an unacceptable response and are tolerating it, the dose can then be increased to 10 milligrams per day. Overall, in the 5 milligram, then up to 10 milligram dose, by the end of 1 year, approximately 50% of patients, or 55%, 50 to 55% of patients will have a reduction in the alkaline phosphatase to less than 1.67 times upper limit of normal, a reduction in the alkaline phosphatase by more than 15%, and a normal total bilirubin. And this was the composite endpoint in the phase 3 clinical trial, not just for obeticholic acid, but for the other two drugs that are now available. In terms of individual responses, for the reduction in alkaline phosphatase to less than 1.67, 55% of patients responded. 15% reduction in alkaline phosphatase, 78% of patients responded. And a normal bilirubin was seen in about 80 to almost 90% of the patients. The main drawback of obeticholic acid, as I said before, is its side effects, which are itching. Obeticholic acid also is a little bit more dangerous to utilize in patients with cirrhosis. It has a black box warning in patients with decompensated Child's class B cirrhosis. And so you need to be very careful if you're using it in patients with cirrhosis and make sure they're a very solid Child's class A and continue to monitor them and make sure they do not progress. If they do progress, the drug needs to be stopped and a different second line agent needs to be considered. Now, our two new kids on the block, elafibranor and seladelpar, also have excellent responses to second line therapies, and using that same composite response, a drop in alkaline phosphatase to 1.67 times upper limit of normal, a reduction in alkaline phosphatase by 15%, and a normal bilirubin, 51% of patients treated with elafibranor achieved that composite endpoint compared to only 4% of patients in control, and 15% of patients achieved complete normalization in the alkaline phosphatase. With seladelpar, the overall response rate of that composite endpoint was 62%. However, the placebo group had a much higher response rate of 20%. When you look at the deltas between placebo and treatment response, the overall responses between the two drugs really do appear to be very similar. Alkaline phosphatase normalization, however, does appear to be a little bit better with seladelpar, 25% versus 15%. Whether this is due to the URSO effect or not, as I mentioned, for that 20% placebo response is not really clear. So both of our second-line therapies provide very, very good response rates and bring that alkaline phosphatase down to under 1.67 times upper limit of normal, which is a good response and puts the patients in a low risk for disease progression. Both elafibranor and citalopar are tolerated very well. The itching actually tends to improve, not worsen, with these two drugs, and the improvement in itching with citalopar is statistically improved. A couple of other side effects that you can see with these drugs are nausea, vomiting, abdominal pain, or headache, but all of these side effects occur in a small percentage of patients. Once we start our patients with a second-line agent, again, we want to see them at 1 month to make sure they're tolerating the drug, and then at 3-month intervals. In general, the response to citalopar and elafibranor and obeticholic acid are all very, very rapid, and usually the alkaline phosphatase will drop and reach its maximum drop in about 3 months after starting all of these second-line agents, and then remain very, very stable throughout the course of therapy. The longest follow-up is with obeticholic acid. It's been around for nearly a decade, and after 8 years of follow-up with this drug, we see no tachyphylaxis. So as long as you can tolerate the drug and stay on it, we do not see a rebound or elevation in the alkaline phosphatase. It stays very stable. The same has been shown, although with less long-term follow-up, since they're newer drugs, with both elafibranor and citalopar, with very, very constant alkaline phosphatase once that nadir is reached, and it's reached very quickly again at 3 months. So once we have patients on stable doses of these medications, we want to monitor their symptoms and see how their itching is doing. We want to monitor that alkaline phosphatase and bilirubin and make sure it's staying low and the disease is suppressed to the best it can be. We want to monitor for disease progression. We want to reassess fibrosis periodically, and we can use that GLOBE or UK PBC score intermittently, maybe annually, to recalculate the risks of disease progression. So once we have our patients on stable doses of URSO and second-line therapy, and we do not have an acceptable fall in alkaline phosphatase, that alkaline phosphatase remains greater than 1.5, 1.67 times upper limit of normal, what can we do at that point? We know that's an unacceptable endpoint, and we have to do something else. So there are other agents that we can start to consider, so-called third-line agents, that in small studies have been shown are effective, but large-scale phase 3 clinical trials have not been done yet. The most popular of these agents are the fibrates, both fenofibrate in Europe and benzofibrate in the US. And these agents have been shown to further lower alkaline phosphatase when added to either URSO alone or URSO plus a second-line therapy drug. Previous studies mostly have been done with obeticholic acid and URSO. In addition, we want to continue to monitor patients for their pruritus and disease progression. Hello, this is Mitchell Shiffman. I am director of the Liver Institute of Virginia at Bon Secours Mercy Health. Finally, let's take a look at emerging treatments for primary biliary cholangitis and look at the latest data on some of these newer agents. Well, there are several other interesting drugs that can be utilized in patients with PBC that continue to have symptoms or continue to have inadequate response. IBAT inhibitors generally work by blocking bile salt reuptake in the terminal ileum and the enterohepatic circulation of bile. This results in more bile acids being delivered to the colon, and as a result, the side effects of the IBAT inhibitors are a slight increase in diarrhea symptoms, which is sporadic and occasional. Fibrates and PPAR, other PPAR agonists, act by targeting gene regulation and cause the transcription of anti-inflammatory proteins and other proteins which affect lipid metabolism. As a result, they can tend to lower serum cholesterol and free fatty acids in some patients, and they can also reduce inflammation, particularly bile duct damage, which leads to a reduction in the alkaline phosphatase in PBC. NOX1 4 inhibitors, such as cenexabab, reduce NOX inhibition and leads to reduced cellular inflammation and reduced cellular injury by interfering with free oxygen radical damage to cells. In the previous section, I already mentioned the fibrates, and both fenofibrate, benzofibrate, as well as other experimental fibrates have been evaluated or in the process of being evaluated as another add-on treatment for patients with primary biliary cholangitis who start with very high levels of alkaline phosphatase, comes down a little bit with the urso, comes down more with our second-line therapy, but still need additional therapies. For patients with PBC that have severe itching, IBAT inhibitors are now being evaluated as a specific treatment for the itching. These were initially utilized in children with severe cholestatic disorders such as PFIC and Alagille syndrome who have terrible itching, and was shown to statistically improve the itching and actually delay the time at which these young children required liver transplantation. There are several studies ongoing now using IBAT inhibitors for treatment of primary biliary cholangitis and other cholestatic disorders like PSC. And some of that data will be presented at upcoming meetings later this year and early next year. And it is very, very exciting. My own experience with the IBAT inhibitors as an investigator in these trials is we're seeing significant improvements in itching. NOX1 4 inhibitors have also been looked at as a way to prevent cellular injury in cholestatic liver disease, but the data on these is much more premature. So we do have exciting agents that we can add, both for the side effects of PBC, such as pruritus, as well as to further bring down that alkaline phosphatase and hopefully further prevent disease progression and improve survival and reduce the need for liver transplantation in patients with primary biliary cholangitis. There are several exciting trials undergoing for the IBAT inhibitors. Linarixabat is being utilized in a clinical trial called Glimmer. In preliminary data has shown significant differences in itch scores compared to placebo and statistically significant improvement in itching. And Valoxabat has been utilized in a study with obeticholic acid and shown to reduce itching both from the disease as well as itching that's a side effect of the obeticholic acid. So there are very exciting data on the way to make our second-line therapy drugs more effective or to deal with the side effects of PBC, which are not being addressed by second-line therapies. We've mentioned benzofibrates as well as fenofibrates that have been evaluated. And there's an upcoming study combining obeticholic acid with a benzofibrate. The preliminary data on that study shows about a 70% response rate when combining obeticholic acid with a fibrate, with benzofibrate, in the treatment of PBC. And that is a very exciting number to achieve significant lowering in alkaline phosphatase. And there's another PPAR called Suller-Glitazar, which is also in preliminary phase 2 studies, again, also showing reductions in alkaline phosphatase. So the PPARs are clearly a very useful category of drugs for treatment of PBC. We have 2 good ones on the market now, and we may have a few more coming down the road in the coming years. We have great medications for PBC now. We have URSO and very, very effective second-line drugs. We've got a couple of those third-line drugs in the pipeline, which hopefully we can add to our second-line therapies. In addition, in the future, we may be able to add second-line therapies to each other, particularly those second-line therapies that have different mechanisms of action. Our overall goal is to get the alkaline phosphatase normal in this disease. And once we get the alkaline phosphatase normal, we will be able to completely prevent disease progression, prevent the need for liver transplantation, and improve life expectancy for all patients with primary biliary cholangitis. We also have good therapies for the extrahepatic manifestations of PBC. The itching, which is the most obvious extrahepatic manifestation, and we're going to see a lot of data coming out on the IBAT inhibitors, and their huge effectiveness in treating pruritus and eliminating pruritus in the vast majority of patients with PBC in the future. So the future is bright for patients with PBC on lots of different fronts, both for their disease and for their extrahepatic manifestations of their disease. Well, remember, our ultimate goal in treating primary biliary cholangitis is to normalize that alkaline phosphatase. We can do that in a small percentage of patients with URSO. We can do that in a much larger percentage of patients when we combine URSO with a second-line drug, obeticholic acid, elafibranor, or citalopar. Hopefully, in the future, we'll have additional agents that we can add to that small group of patients that have still not achieved normalization of alkaline phosphatase on 2 drugs. And that is the way we will prevent all patients with PBC from progressing, improving their overall mortality, and eventually completely eliminating the need for liver transplantation in these patients.